Hi, this is Joyce Pellino Crane. I'm the news director at WestfordCAT, and I'm here today with Dr. Scott Paparello. He is a internal medicine physician who specializes in infectious diseases. And you're with Acton Medical Associates?
Yes, I do internal medicine at Acton Medical Associates, and I also work at Emerson Hospital doing consultations for infectious diseases and infection control.
So tell us a little bit more about your background. You have an interesting background. You were in the Navy, right?
Yes, I did my training internal medicine in the Navy, actually in Portsmouth, Virginia, but then became interested in infectious diseases, probably because we saw so many from all over the world while taking care of patients in the Navy. So I did a fellowship in infectious diseases at National Naval Medical Center in Bethesda, Maryland. That was for 3 years there, and then served some other time in the Navy, and then came out to private practice.
And what does it mean to be an infectious disease physician?
We usually get called by other physicians to help with tough infectious cases, how to manage them or how to diagnose them. Obviously, when things such as the COVID-19 comes about, then we're enlisted to help with diagnosis, management, epidemiology. I help with the infection control issues at Emerson, how to prevent spreading of infections among patients and healthcare workers, which is obviously a huge issue currently.
How are they handling things at Emerson? Are they overwhelmed, or do they have what they need for supplies? What's going on inside Emerson?
I think at this point, things are fairly stable and the supply chain is fairly good. Initially, when we weren't quite sure how many patients we were going to get, what kind of surge we were going to see, the supply issues were a little scary with the lack of N95 masks, which I'm sure everyone's heard of. Emerson being a relatively smaller community hospital, we did not get quite the surge that some of the city hospitals did, but we certainly have been busy and remain busy with a number of cases of COVID-19, some quite severe. But I think right now, as far as bed space and ventilators and PPE, I think we're in fairly good shape.
So what are you doing for masks?
If you are taking care of someone who has an infection, a coronavirus infection, we wear the N95 mask, perhaps with a shield over it or at least some eye protection, gowns, gloves. If someone is suspicious, we use the same, or suspect case, we use the same type of materials until we can rule someone out. If someone comes in the hospital with fever and we come to the conclusion that they don't have coronavirus infection, then we can relax those. But in general, we're very careful wearing a significant amount of PPE until we're sure the patient is not infectious or has some other diagnosis.
Can you talk a little bit about how COVID-19 spreads?
Well, I think that's one area that we're learning quite a bit about. I think everyone knows the common cold viruses, of which the coronaviruses that we have already in the area produce some of those, and influenza, that most of these are transmitted by coughing, and then coughing what we consider these fairly large droplets. Now, when we say fairly large droplets, they're not visible. You can't see them fly out of someone's mouth, although sometimes you can, I'm sure. But for the most part, you're not seeing them. And then you can either inhale them directly if you're within close proximity, and that's where that 6-foot range comes into mind or comes into play.
Social distancing.
The social distancing, that's why the 6 feet is recommended. But the other thing that happens not infrequently is someone coughs or goes to their mouth and they're ill and then touches a surface. I mean, these viruses can survive on surfaces, doorknobs, toilets, common areas. So if someone was just in an area and then you touch that area and go to your mouth or eye, that's another way of getting infected. This virus might be a little different. There's concern now that it might be spread a little further or more easily through the air a little further than the usual cold viruses or influenza, as we're seeing cases in confined areas spread very quickly. So I think there's at least some concern that this may be slightly more airborne as opposed to just droplet precautions, droplet spread like influenza. But it doesn't seem to be spread widely through the air, such as tuberculosis or measles, which if someone coughs, those microbes stay suspended in air for quite some time and even quite some distance at times. It doesn't seem to be as contagious as that, but it is a highly contagious infection.
So is it the structure of the virus that keeps it airborne? I'm imagining a little helicopter or something. You know what? Why
No,
would
it's
Lyme
probably
virus
it's
be
probably
more?
just no. I think it's just probably more the level of virus in the airway is quite high.
Mhm.
So if you're coughing up even smaller droplets that go a little further, that there's enough virus to be dispersed that way, as opposed to they don't float in the air, so to speak. It's probably just that when someone has infection, they have significant numbers of the virus in the nasopharynx, meaning the nose back to the throat, and then certainly in the lung tissue. The interesting part of this, though, is that people can have the virus and not even know it and be spreading it either before they get any symptoms or sometimes without ever getting any symptoms.
Yeah.
That's really what has been caused some of the spread that we've seen so easily, where people are exposed to patients who have the virus but don't even know they have it themselves.
Do you have any idea how many COVID positive patients are at Emerson right now?
I can tell you there's 22, I believe, and I think about another 10 to 12 suspected, so where we haven't proven it by the test yet, but they're highly suspected. I know there's at least 4 or 5 in the intensive care unit and some on ventilators.
Oh my. Well, we'll hope for the best for all of them.
I mean, the downtown hospitals like Mass General, Boston Medical, they have, upwards of 100 people in the ICU or on ventilators at one time.
It's just remarkable how this all happened. How is this virus different from the flu virus? The flu is a virus as
The
well.
flu is a virus, and it's somewhat similar in that it's what we call an RNA virus. Their genetic material is RNA. It does behave very similar to the flu. It attaches to different receptors in the nose and the pharynx and the lungs, which may be why it might be a little more contagious and why it might be more severe in some people. But for the most part, it's very similar to the influenza as far as how it spreads. The influenza, depending on the strain, if there's a brand new strain, can be quite severe and cause severe pneumonia and deaths, such as these major epidemics we have periodically. This strain of coronavirus is certainly much more virulent or aggressive in some people than the typical influenza that we see on a seasonal basis. I have been struck by how variable the clinical course can be, from having no symptoms with this virus to unusual symptoms without respiratory symptoms, such as the COVID toes you might have heard of.
No,
But on the other hand, in the right person, especially the elderly or those with risk factors, it can be extremely severe and extremely deadly, as we've learned.
yes. What is the COVID codes, did you
The
say?
COVID toes
Toes.
is a situation where people get red and irritated toes, primarily children, but some young adults. And that may be the only manifestation they have, but it seems to have come up as unique to this virus, or semi-unique to this virus in this epidemic. The other thing is a significant loss of smell. Any virus can do that, but this seems to be particularly prone to causing loss of smell and taste for a period of time.
If they survive this period of illness, does the sense of smell come back?
Typically, based on prior epidemics where that may be a symptom, or other viruses, it should return to normal. It can take a while. Cases I've seen so far, it does seem to return fairly quickly, meaning within a number of weeks.
Well, that's good to hear. So there's this swab test, nasopharyngeal.
Yes.
Did I pronounce that
nasopharyngeal.
right? What is that all about?
Well, if you're looking to make the diagnosis, the best way is to find the organism itself. Viruses are typically very hard to culture, so we rely on what we call PCR, which is a way of amplifying the genetic material, the RNA, and detecting it in wherever the virus is. The nasopharyngeal swab is a swab that goes through the nose, but deeper to the back of the nose where the pharynx is, the back of the throat, but up a little higher. That seems to be the best swab to detect the viral DNA. So that's where you'll hear the PCR or the nasopharyngeal swab. You can do the swab in the mouth, but it's not quite as good as doing it through the nose into the nasopharynx. But that's the way to diagnose an acute infection, because you're actually finding the virus material itself.
So deep in the caverns of your nose.
Yes, we don't like to call them caverns. We call them turbinates or the nasopharynx. But yes, caverns.
You're way over my head already. So let's see. Some people are diagnosed with COVID based on their symptoms without doing a test. How is that possible?
Similar to what we do in influenza season, if we know influenza circulating and someone calls and says, I have this, and this symptom, then you can with fairly good certainty say that's what it is and manage it appropriately. In the midst of this epidemic, without a lot of other viruses circulating currently, including influenza, I think if someone calls and say they have fever, sore throat, cough, I think you can reasonably make the diagnosis without testing. Now, some of that has come about because the tests were in such short supply, and they are getting to be more available now. So sometimes we had to set criteria for whom we're going to test, meaning the high-risk patients or those more severely ill. But for the most part, people currently with those kind of symptoms, you can probably assume that you have the virus and act accordingly, which means stay at home, distance yourself, supportive care, symptomatic care, unless you're getting significant infections or symptoms such as shortness of breath, those kind of symptoms.
Where you might have pneumonia.
Yeah, if anyone has significant or severe symptoms, they should seek medical attention, call a physician, and if tests are available, which they seem to be getting in better supply, avail themselves of that.
What's the current recommendation for people diagnosed with COVID who do not require emergency attention?
If you don't require significant medical attention and have either been tested positive or presumptive diagnosis, then you treat it pretty much like you would a cold. Recommend Tylenol for fever as opposed to Advil or some of the anti-inflammatories. Obviously rest, hydration, and staying at home. Now, you want to isolate yourself from obviously society, but even from your family within the home as best as that is possible. You want to cover your mouth, wear a mask if you have to be exposed to someone. You should be wearing a mask, and conceivably they should be wearing a mask as well. Don't want to share items as much as possible. But basically, symptomatic care and isolating oneself.
Yeah, I was reading your background, and you have a family at home, and so I'm wondering, because I just live with my boyfriend, but you're living with 3 other people. Is it hard when you walk in your house, what are you thinking as an infectious disease physician?
Well, my wife's a nurse, so she's working too. So when either she or I get home, we go right up and take a shower, get rid of those clothes, although clothes is not a main way of transmitting this. We take a shower, and assuming neither of us have symptoms, then we still stay a little bit apart, but we don't necessarily stay 6 feet apart in the house. My daughter's home from college. She tends to self-isolate herself anyway, so that's not an issue. She comes down, grabs some food, and then it goes. But no, if we're sitting watching a movie or something, we're sitting a little bit further apart than we typically would. That sort of thing. Just being careful on the thought that myself or my wife or even my daughter, though she has had limited contact, could be infected but not symptomatic and might be able to spread it to someone.
Yeah.
So we're very careful that way.
Tell us a little bit about the blood test for antibodies that's being talked about. What is that? Is there a name for that?
Any blood test for looking for antibodies, we call a serology, looking at your serum, something involving your serum. When someone gets an infection, they typically will develop antibodies against it, and that's one way of diagnosing an infection. But in retrospect, they're rarely useful at the time someone has an infection because it takes your body some time to develop antibodies to be useful as having said someone had it. Because a lot of viruses in particular, we haven't had any direct diagnostic tests such as the PCR on the nasopharyngeal swab. So we would rely on serologic tests, serologies, but that would be after the fact. The interest now is to see who might have been infected asymptomatically without having any symptoms, but actually had infected. But the bigger question is going to be that if someone has these antibodies, are they protective? Do they mean you are not infectious to others? Do they mean you can't get infected again? And if so, for how long? And these are all tough questions, but there's a great deal of study going on now. The test is being used more for population studies. I know Mass General is doing one locally in the Boston area to see who might have had it. New York has had serologic studies showing, a fair number of people may have been infected with or without symptoms. But the bigger question is, what do these antibodies mean? Are they protective? And do they mean that you are no longer infectious to someone else?
What are your hopes for a vaccine in the near future?
There are some interesting candidate vaccines out there. One group in Oxford, England, was studying getting a vaccine for the previous corona outbreak, SARS, but it turns out they didn't need it because that was controlled with infection control methods, et cetera. So they were able to gear up fairly quickly and develop a candidate vaccine. Viral vaccines can be anywhere from fairly effective, such as the influenza vaccine. It's not perfectly effective, but it does minimize and prevent the disease in many people, or infections such as measles, where a vaccine is highly effective. So we'll have to see it going forward. One is, are these vaccine candidates safe, and do they generate the immune response you're looking for? And then the bigger question is, are they protective against the actual infection? And those studies are going to be difficult, especially if the epidemic dies down and there aren't a lot of cases around. Then we won't know. We'll have to wait till the next wave, so to speak, to even study these.
Do you think that the wave will die down and it won't come back? Dr. Anthony Fauci, who, by the way, you said you've met and know. I'd like to talk about that a little bit. But do you think that?
Well, I wouldn't say I know him. When I was down in Bethesda, Maryland at the Naval Hospital, which is right across the street from National Institutes of Health, he would come over and give lectures or sit in on city rounds. And he's quite an impressive feature, although many of the doctors there from the National Institutes of Health were all very impressive. And so I think, I would trust him. Not that he knows everything. I mean, there have been some surprises with this epidemic. I think the whole scientific community was a bit surprised in how many people are asymptomatic and how this can be transmitted from people who are before they develop symptoms or never develop symptoms but can still transmit it. I think that's a little more surprising than we've seen with other influenza outbreaks or even coronavirus outbreaks. But I think, if you listen to Dr. Fauci in general, he'll give you a good response, an honest response that, for the most part, you can trust, with the caveat that there are things we don't know or didn't know about this particular virus.
So do you think, though, it will die down and not come back?
I really can't say. There's so many different models out there. I mean, typically when we see seasonal outbreaks and coronaviruses are typically winter type viruses, the ones that circulate in our community on a regular basis. This one obviously has been circulating in southern hemisphere to some degree, where it's hot, where it's dry, where it's humid, lingering on a bit more. So whether it kind of dies down and then we see a resurgence in the fall, which is probably what most people are expecting to some degree, or it dies down and doesn't come back, or never dies down, just kind of trickles through the society over the next few months. I think it's very unclear to me.
Last question. In the early weeks of becoming aware of this virus, we were hearing that it was transmitted from an animal to a human. Do doctors and scientists still believe that, or is that changing?
In general, coronaviruses, when we see a novel species, a new species, they seem to be related from mixing viruses in an animal community, primarily bats, but then other animals can transmit it. For the Middle East respiratory syndrome, it seems to be camels of all things.
Oh.
The origin very likely was from an animal at some point, but it's not clear whether it was from that animal market. I think there's data that it was probably circulating well before that, and that just happens to be where there was some groupings of people. Now, whether it came from a lab in China, that's a whole nother ballgame. That the science probably points away from that, but I can't really comment on that.
Well, Dr. Paparello, thank you so very much for taking the time to speak
Sure.
with us today. Sure. I really appreciate it.
Good.
I'm Joyce Pellino Crane, and you're watching WestfordCAT News. Take care.